Welcome to Healthcare Careers in Focus. Today we have Zara joining us to showcase the career path of midwifery.
So, hi, my name is Zara. I am a midwifery clinical tutor and I work at a local hospital maternity unit and at a local university. Next slide, please. So, my career journey. So, I didn't always want to be a midwife. I started off by studying biological and medicinal chemistry at a university, which sounds as boring as it was for me. So the plan there was to complete that and then to go on to PGCE and then become a secondary science teacher. However, life had other plans for me. And 2 years in, I then took a break and decided that wasn't the career for me and looked into midwifery a lot more. I then started my access to higher education in midwifery at my local college. Which then I completed and did all of my interviews to get into university, and then got into my first choice for my BSc in midwifery. And my cohort was one of the first cohorts that included something called NIPE, which is our newborn and infant physical examination. So it's the baby checks. So we get an extra little bit of qualification, which is now included in pretty much all degrees. I then moved on to preceptorship after I completed that, and I stayed at the trust that I trained in. So I rotated around all the different areas. I think we had about 3 months in each area, 1 month in our low-risk midwife-led unit. And then I ended up as court staff on our consultant-led unit, which is our high-risk delivery ward. I was there for about another 6 months before I then ended up going out into community. So I went from the high risk to the low risk community care. And I stayed as a community midwife for the next 5 to 6 years roughly. So in community, I started and I was still a band 5 and I held on to that for a little bit for the on-calls because in community you're on-call as well until I felt confident enough to then go for getting my band 6. While I was out in community, we moved over from the old mentorship to our SSSA NMC standards, which is the standards for supervision for students and assessment. I did my training for that, which because of technology and life, we could do online as well. So I did that nice and easily online. And then I did a course to become a professional midwifery advocate as well, which led into me then further doing our mental health first aider training a little bit later on. And I'll talk a little bit more about PMA later on. Not long after I completed that, I then started looking for the next steps in my career and found a job online, which looked really interesting for me. So going round full circle back into that teaching role again. So there was the clinical tutor for midwifery role that came up. At the time for me, I was like, it's the first time I've applied for a specialist role. Didn't think anything would come of it. Got interviewed and then got the job. And I started my current role in 2021. It was a new position in the hospital that I work for. So there was minimal guidance. It was, here's the job, off you go, here's your job spec, make it what it is. So it was this new role to support our students in practice, so specialist there. And it is a split role between the hospital trust and our local university. So I do a little bit of both on both sides. And when we look at the day in the life of, I'll tell you a little bit more about what I get up to now. During that, I went into the lecturing side as well for this role and became module lead for some modules. So I've had that experience there in the university. So a first year and a third year module I've had that experience on. And I've recently just redone my NLS, so my newborn life support So the Advanced Newborn Life Support Practitioner training, which I've now been put forward for my general instructor training. So that is the next step in my development of myself in my role as well. So day in the life of, so I've split this into two parts because my community midwife part of my career was such a big part, and it affects a lot of the way that I teach and the way that I practice now. So the day in the life of a community midwife. So in community, you encompass all antenatal, intrapartum, and postnatal care. So for me, we would work 9 to 5. However, we would get up in the morning, we would call into the hospital for what we call our ring outs, which is getting the information for all of the women that have been discharged home from the hospital over the previous 24 hours. We would get them around kind of 7, half 7 in the morning. We'd have an electronic diary, good old Microsoft, and we would put all of that information on that electronic diary, which is accessed by the team. And then we would organise that within the team. So if they were some of our women, so we would see our women all the way through the antenatal period. So if we recognise, oh, that's one of my ladies, then I would put her under me to go and visit. If not, the same would happen with the other members of the team. If there was someone that was on there that had been out of area and we hadn't seen before, then we would just look at the geographics of who was going into that area so that we could make the best use of our time for the day. I could then potentially go on to doing my antenatal clinic. So that some of my clinics would be half-day clinics, some would be a full-day clinic. I used to have one which would run from 9 to 5 on a Monday. Some days I would just have a clinic in the afternoon. Those clinics, we'd have appointments ranging from someone turning up before they've even had their booking appointment because they'd been signposted to us. So we would help them fill out that referral form and have some discussions with them. We'd see them routinely throughout their pregnancy. So we see women at 16 weeks. Following their initial scans to check that they've had all the referrals done, start checking their blood pressure, checking their urine as well. And then we'd see them again if it was their first baby at 25 weeks. That would be after they've had their 20-week anomaly scan in the hospital. We would check that again, everything that needed to have been done has been done at that point. We'd have discussions about antenatal classes, their plans for birth, where they're planning on having their baby, talking about breastfeeding information, infant feeding. Again, we do our clinical tests. So every time we're seeing them, we're checking their blood pressure and their urine. We're looking out for signs of things like preeclampsia, gestational diabetes, infections, checking on their mental health as well. If it wasn't their first baby, we wouldn't see them till the next appointment, which for all women was around 28 weeks. That one we'd be doing blood tests as well, checking for iron levels, making sure if they were at risk for things like gestational diabetes, so diabetes in pregnancy, that they had the appointments already for going to have further tests in the hospitals. If they were needing any serial scans, so repeat scans throughout their pregnancy, that they had all of those appointments, consultant appointments, and again, checking have they booked any antenatal classes, talking about their preferences for where they want to have their baby, infant feeding, checking mental health, and answering any questions that they had. We'd then see them a little bit more frequently because at this point it's very ad hoc, so there's big gaps between those appointments. We'd then see them again around that 32 weeks, then 34, 36, 38, 40 weeks, and then at 41 weeks if they had gone past their estimated due date. At that 36 weeks is when we go through their birth preferences. Otherwise, all of the other appointments, we'd routinely doing all of the same things, but from 28 weeks we would start measuring their bump as well to check on the growth for baby. And if baby's showing signs that they're growing too fast or too slow, we'd then make the relevant referrals in for scan. So a lot of the antenatal care for community midwifery is a lot of screening and checks and making those relevant referrals wherever necessary. Once my clinic was finished and I'd done all of the computer work, the paperwork, and sent off any blood samples that I might have done, any swabs, anything that I needed to do, I might have some meetings. So there'd be a lot of safeguarding meetings. So anyone that falls under the safeguarding team, for care for them, the unborn baby, then we would have the relevant meetings for that. So there was a lot of talks about making sure the right support was in place, that they've got family support. Does there need to be any professional support in place, to try and make sure that that baby is coming into the best environment that they can? Or then I could potentially just go on to home visits, or I might have a full day of just home visits. So our home visits, some might be antenatal, some might be postnatal. So antenatal, so we'd sometimes do bookings at home. So that's that initial medical history appointment. So taking the entire history, booking all of any referrals, booking your first scan where you can get your estimated due date from. We could be doing their enhanced care visits, which I'll discuss in our case study a little bit later. So for any women that might need that enhanced care where just going to the GP surgery for routine appointments might not be enough for them. So we might have to see them a little bit more frequently, or it might help them if we see them in their own environment. Also seeing them in their own environment, we can check further for safeguarding. We might be seeing them for safeguarding appointments, so it might be part of their plan that we have to see them at home, check their home environment, check that it's clean, safe, who is around them, that it's appropriate for a newborn baby to come into. And then home birth checks. So around that 36 weeks, if they decide to have their baby at home, we do a home birth checklist. So making sure that they're aware of what happens in a home birth, the things that we would expect that they would need to get to make sure they're fully equipped. So if they're wanting to hire birth pools, hire pain relief, so things like TENS machines, what we would bring with us. So we would bring gas and air, those kind of things. And then making sure, again, it's not a 12th story flat with no lift. So therefore, in case of emergency, how are we getting them out of the building? Can an ambulance get to them? All those kind of things as well. And is it safe? Is it a house of multiple occupancy? So therefore, where are they going to be? Is it going to be private? Have they got those safe spaces to be able to have their baby? It could be postnatal visits. So a lot of our home visits were postnatal. That was the big chunk of our home visits. So for us, where I used to work, it was initial visit, so the day after they came home, to check how things had gone overnight. Is baby feeding okay? They usually come home the night where babies decide that actually they're starting to get hungry and they're awake all night wanting to feed. So we do feeding assessments, checking if they're breastfeeding, checking how that's going, making sure baby's feeding okay. If they're bottle feeding, again, making sure that baby's feeding okay and that they're up to date with the information on how to make up feeds, how to sterilize their equipment correctly, making sure that they know how to tell if baby's getting enough food in. Again, lots of signposting, lots of information giving, talking about things like safe sleeping, car seat safety, what to expect for the next appointments, talking about the next screening appointments, making sure that babies' checks had been done in the hospital. Have they got any medication for mum that needs doing? Checking any wounds, stitches, all those kind of things as well, making sure their bleeding's okay. Again, mental health, making sure everything's okay there. NIPE, so that's that newborn check that I spoke about earlier. So it could be that we would be going in to do one of them at home. So the hospital that I worked at, they wouldn't have to stay in the hospital for that to be done. They could be sent home because there was enough of us that were trained to do them, that worked in community, that they could go home. And then we could do that check at home. So we would be the 4 key areas there. We'd be checking eyes, heart, hips, and if little boy, testes. And then just a general top to toe MOT, making sure that everything is where it should be. There's no extra bits, missing bits, bits in the wrong place, anything that we're concerned about for baby. If all is good, then that is done. We're happy with baby. And then we give them the information, obviously, that gets repeated by the GP, etc., 8 weeks, and then talk about our next screening, which would be the day 5. We'd see them day 3 and then again day 5. So day 3 was more of a infant feeding, so making sure that baby's not losing too much weight. It's really normal for babies to lose a little bit of weight between birth and day 3 and 5, but checking in at day 3 helps us to identify those babies that are losing too much weight. So therefore, is there something going on with the feeding that we need to address before we leave it any longer? And then day 5, again, potentially weighing that baby, and that's when we'll be doing another screening tool on baby. Checking for a myriad of different conditions, so certain things like cystic fibrosis, metabolic disorders, all sorts of different things that if they're picked up nice and early, then they're treatable, but they could have some potential serious effects on baby if they were completely missed and not checked at all. And again, checking mum's okay, checking on the wider family, making sure that there's nothing else going on in the house that they could get further support with to help them with that parenting journey. Could just be a feeding support visit, so we'd get a lot of breastfeeding support requests, especially if it was the first time that they've breastfed a baby and they're struggling, and there's something just not quite right. And so therefore we could go in, and a lot of the time it would be something really simple. Sometimes it would be a little bit more complex and we'd have to get other agencies involved. So we'd have our feeding coordinators. It might be that actually something's really not quite right and we need to refer in. Um, Again, wound checks, so checking cesarean wounds, looking for signs of infection, removing sutures or staples, checking perineal wounds, again, looking for infection, um, rarely removing sutures, but sometimes that was appropriate. Um, Weighing babies, so those babies that have lost a little bit more, we need to go back and weigh them repeatedly once they've got a feeding plan in place to make sure that that's working. Again, safeguarding visits, so it might be part of their plan if they're on a safeguarding plan that we need to visit them in a certain pattern. Jaundice checks, so some babies can become jaundiced because their livers are very immature, so they don't cope very well with processing all of their red blood cells. So a lot of babies can get a certain level of jaundice, so if it's to the point that we're worried, we can be going in and checking regularly to see, does this baby need further referral or is it improving? And finally, our discharge visits. So somewhere between day 10 and 28, we would be looking at discharging them from midwifery care, because that's about the time that the health visitors then will come in and then take over from us. Um, we would also be on call overnight. So for me, the pattern would normally be that I would be working. So say I'd be working on the Monday, working 9 to 5. Then I'd be on call from 5 p.m. Until the following morning at 9 a.m. I'd usually be rostered to work the next day, but if I was out all night, then I wouldn't have to work that day and someone else would take my workload. So we worked really well as that team. Um, those on calls, it could be for missed visits, so someone's slipped through the net with the communication somewhere. Someone is worried about feeding, or again their wounds, or just needs to speak to a midwife, or for home births, which I absolutely loved. So I would always end up being called out into the middle of nowhere, and have a lovely hour-long journey to get to their house. So with home births, it's always that communication with them going, it can take a little while for your midwife to get here. So we'd always have to make sure we're really well communicating with them as well. So don't leave it for the last minute when you're pushing, because we're coming from home, and if you're calling me at 3 o'clock in the morning, I was probably asleep and I need to get dressed. And so then we would work overnight, calling out our second midwife. So the second midwife who was on call when we get close to birth being imminent. Again, doing all the paperwork, all those kind of things afterwards, making sure all is okay, and passing that information over to the people that are going to be working the following day. And finally, all the paperwork and admin that comes with healthcare. So there's plenty of that in community, as you can imagine. And that is the day in the life of a community midwife. And then moving on to what I do now. So my role now is classed as a specialist midwife role. So as I said, I work at our local hospital maternity unit and our local university. So it is a split role. So I spend half of my time in the hospital, half of my time working for the university as well. Um, so we there are two of us, so there's two whole time equivalent midwife, so a full-time person at the university and a full-time person in the hospital, but we share the workload between us. So if I was on a day working in the hospital, um, I would be making sure I'd be checking for student absences. Are there any students missing who should be in placement? Have they been chased up? Could they be in a ditch somewhere after a car accident and we need to make sure they're okay? Have they forgotten it's their shift? Are they off sick? Have they called in? I do a daily walk around, making sure that all of our students that are in the right places. They have someone that they're working with and that all is okay. I could be writing the rosters, so putting together their shifts. So whether that would be um, in the delivery suite, in the community, antenatal clinic, their non-midwifery placements, so they'll have placements elsewhere, making sure that things are on their roster and any communication from teams, so make sure that the students know who to contact for their non-midwifery placements as well. Lots of emails. Um, Doing something what we call power hours. So we have power hours at our trust, which is an hour in the day for our students that they come out of their clinical placement if it's appropriate. Obviously, we don't want them to leave someone who is just about to give birth and they miss out on having that experience for their placement. But if appropriate, they would come out. And we would either have discussions about something that they've experienced in placement recently. We could be running skill sessions, so things that our students have asked us that they would like to have some more clinical practice on. So we would do some simulation, or we get our other specialist midwives. So we've got our safeguarding midwives, our mental health midwives, our bereavement midwives, fetal monitoring midwives. They all come in and can run sessions for our students as well. And we base that very much on what our students need. So again, lots of communication with our students, lots of meetings. So a lot of our planning, so trying to make improvements for placements, improvements for students, looking after students that might need that additional support, maybe not meeting expectations, and we're having to put extra work in to get them back to where they need to be. If I'm on my uni side of things, I spend a lot of my time working from home. So if I'm not physically face-to-face teaching, I will be sat at my computer desk or dining room table with my laptop doing all of my work there. Again, there's lots of meetings and paperwork, but I could be writing teaching material. So when we started our new curriculum at our university, everything needed to be written from scratch. So one of the modules that I was module lead on, we had to write everything brand new for this module because it hadn't been taught before. So that took a lot of hours of work. I could be marking. So at the moment, we're in our marking season. So there's lots of marking going on. Or I could be physically face-to-face teaching. At the moment, we teach cross-site. So it could be that I'm at one campus one day, and the next time I'm teaching, I'm at a different campus. So teaching different cohorts, or sharing that teaching with other courses, so paramedics or nurses, nursing associates, so doing teaching for them as well. A lot of this role as well is supporting with staff training. That could be something like our shoulder dystocia, where the shoulders get stuck when baby's being born. It could be something like a cord prolapse. It could be our hemorrhage, our life support, so resuscitation. And so all of that is included there, so supporting on that training. Our maternity update days as well. So us as clinical tutors, we give a session about our students, so giving any updates for us about our students that are in practice. So that could be our paperwork. So we've gone digital. So a lot of the work at the moment has been around how to fill out the paperwork, how to log on. It's any feedback that our students have given about working in certain areas, any improvements that we can make, and any feedback that we can get from our staff about working with our students as well. So it's all about making those improvements to make it better for our students in placement and make it so it's easier for them to go through their training and qualify. And then finally, working clinically when the unit is busy. So if it is really busy, we do get called on quite frequently to support. So that could be just working clinically for the whole of our shift. It could be just supporting going and doing some of the infant examinations on the ward, because there's a few of us that have that qualification to do them. It could just be simple as covering someone on lunch break, because none of them can get any because it is just that busy. So we do work clinically, and I work some clinical shifts every now and again. I haven't done for a little while at the moment, but I will work clinically as well just to make sure that I'm still keeping up my skills as well. So even though I've come out into that specialist role, I still go onto I suppose, the shop floor. Um, to work those clinical shifts on our delivery suite, to still work with women and their families and birthing people. So it is still a very varied job. Next slide, please. So rewards and challenges of being a midwife. So rewards, advocacy and empowerment. So being able to advocate for the women that are in our care and their families, their partners, those babies, and empowering them. There's nothing more magical than empowering someone who is in labour or in that antenatal period that doesn't think they can do it, and you give them that confidence that they can. In my current role as well, for our students as well, the students that are struggling or might be nervous, and in giving them that empowerment and advocating for those students, to get them to where they need to be. Making that positive impact on women and their families. So just being that person that can have that impact by giving them that piece of information, by doing that little bit of support, that skill, that little bit that just has that impact on them, and then you see that change in them as time goes on, and you're like, yeah, I really made a difference there. And being able to be part of such a special moment in people's lives. Every birth is different. That will never happen again, that one birth. I've got 3 children myself. Every birth was very, very different. And I remember each midwife that was there for all of them. And being part of that moment with them, because it is life and death. Things can happen to both mum and baby. And that's that first moment that that baby comes into this world, takes that first breath, the moment that they become parents to that baby. Being part of that, nothing else can beat that as a job, in my opinion. And then developing students, and I'm newly qualified into those confident practitioners. So in my current role, again, supporting them, giving them that support, those skills, that learning to get them to the point where they can go off and be those confident practitioners, and watching them go through their careers as well. So like I say, I've only been in my current role since 2021, but even now I'm seeing students that were students when I first started and now qualified, and seeing their confidence and seeing them flourish. So there's definite rewards to midwifery. However, there are always challenges in all careers. So for midwifery, there's always those competing priorities, workload challenges. So in my previous job as community midwife, our workloads kept increasing and increasing, and my caseload would get bigger and bigger, and all the paperwork and admin that goes along with that, as well as doing the actual caring for women. It becomes challenging at times. You're like, oh my God, I've got all of this that I need to do, but I want to spend more time with this patient, with this woman, with this family, with this baby, to be able to do it. And it's trying to find that balance. Um, the not so happy side to midwifery, there's always going to be difficult patients, bereavements, the safeguarding side of things that they do stick with you. Throughout your career, you look back and go, could I have done anything different? Is there something that I could have done? Even though the vast majority of the time is you did everything that you could have done. You did everything to the best of your ability. There's nothing else that could have been done, and still things don't always go well. So we like to look at birth and pregnancy through rose-tinted glasses, but the reality sometimes for some people can be very, very different. And then in current role, failure to fail and underperforming staff and students. So sometimes you can have people that you're working with and you really, really want them to succeed, but for some reason they're just not meeting that. So, and it's really hard on a personal level to fail someone and say, actually, you can't pass this. This isn't the career for you. So from that kind of more like management or training positions, it is really hard to have to say that to someone when, especially if they've gone partway through their training or they're now qualified, and you're saying, actually, I don't think this is the career for you. It is really challenging. So there's always rewards and challenges. But for midwifery, they're the ones that jump out to me the most. Next slide. Um, So advice to my younger self. So take every opportunity. So taking those opportunities to learn, to find out things, taking if someone offers something, say yes, always say yes. There's always something to learn, and all that's going to do is make you more rounded of a practitioner. No matter what career you go into, you'll always learn something new, something different. Prioritize yourself. I've always been historically very bad at that, and it's very cliche, but you can't give from an empty cup. Midwifery is a caring profession, and it is really, really hard, and you'll get burnt out very quickly if you're not looking after yourself and taking that time. So if you do have a really difficult case, making sure that you're going to your professional midwifery advocates, so your PMAs, for that support. So our PMAs are there to kind of signpost you and support you into things if you're struggling. They're there to help you further your career, so quality improvement. So yeah, making sure that you're prioritizing yourself, and making use of things like your PMA services, or just having a spa membership. So anything that is going to look after yourself. Don't take it personally. So again, if you have difficult cases, difficult people that you're working with, difficult patients, don't take it personally. You are there, you are a uniform. You are the person that is representing the institution, the NHS, or if you go into independent midwifery, you're representing the profession, and it's not always stuff that's directed at you specifically. It's just directed that you're the person there that's getting their frustration taken out on. So don't take it personally, otherwise you will beat yourself up about everything. And for midwifery, it is totally worth it. I can't think of another career that I would want to be doing, no matter what route you follow. So whether that's going through doing your A levels or your college course and going straight into direct entry, if you're changing careers coming into it, if you're doing apprenticeships, if you're doing nursing and then coming to midwifery, it is absolutely 100% totally worth every single second. Next slide, please. So my case study, it's looking at individualised care planning. So this is based from a lady that I worked with when I was in my community day. So I have called her Lisa for this. It was not her first baby, so P1 means that she had a parity of 1, so she has had 1 baby before, and she had had a previous SVD, so that's a spontaneous vaginal delivery. So she'd had a previous vaginal birth with no complications. She did, however, have a history of eating disorders. And she had a history of and ongoing mental health and was currently medicated on a variety of medications for that. It was mainly anxiety, but it was a little bit of a mix in there. She, however, had no other medical or obstetric history, so pregnancy history of note, so nothing else that we needed to take into consideration. So her background, well, the background for this case. So I was working as a community midwife for her GP surgery, so I was linked to the surgery she was registered at. Lisa, she does not follow the standard approach for fundal height measurement. So as I said earlier about us measuring their tummy, their bump, to keep an eye on baby's growth, our standard approach at the time was using a personalised growth chart, which involved needing to take their weight, their height, you'd take in their ethnicity, you'd put in any previous baby weights, all these little bits of information about them, and that would get them a personalized growth chart. So you'd be able to see if a baby was growing too big for that person or too small. So someone that is 6 foot tall, then weighs a lot more, would be it would be very easy for them to have a bigger baby than someone who is 5 foot and weighs 50 kilos having the same sized baby, and vice versa. A baby that would be normal for that 5 foot 50 kilo person would be too small, and we'd be worried about the growth for someone who was much larger of a person. So because of Lisa's history of eating disorders, she did not want to be weighed because that could trigger her. So she had been hadn't been suffering actively with her eating disorder for some time, but she knew that if she was weighed and she knew how her weight was, that would help, that would start to trigger her eating disorder, which she wanted to avoid. So we couldn't use our customized growth charts. We had to use the old school version, which was a standard growth chart, which in whole our trust did not use. I'd gone on annual leave, and Lisa had seen another midwife at my surgery for one appointment. This midwife was not aware of the full extent of the history for Lisa, and that we had used this plan before, and was not happy to just measure on the old chart. So therefore had tried to refer in for growth scans, refer to consultant appointments, and caused a big cascade of events, which for Lisa affected her mental health. So I came back and had some messages from her, and she was quite distraught and very upset. She was hoping to plan for a home birth for this baby, and felt like she was being bullied out of it by procedures and policies, which was our standard approach rather than her individualized care. Next slide, please. So support that I gave to Lisa. So we moved to enhanced care. So that involved home visits. So she would not be seen in the GP surgery. So I wouldn't go on leave for a week and not realise she was booked in for that clinic on that date. So she would be in my diary, where I would see her on my working days as my home visits. So therefore, it was that full continuity of care, which was perfectly appropriate for this person. So we did some outreach to her mental health team because she wasn't due to have any contact with them for a little while. So we spoke to them to get them to put a little bit of extra support in place for her in the meantime. And then I had all the lovely discussions with our consultant midwife and our obstetric team to kind of stand down all the referrals that were being made, saying, actually, we've got this plan in place for her. A consultant midwife agreed that, yes, that was appropriate and we didn't need any further support. So there was a little bit of that MDT approach, so involving her mental health team, our consultant midwife, and our obstetric team in all of those decisions to make sure everybody was happy with our plan going forward. So, like as I said, that multidisciplinary working. So for Lisa, she had input from our community mental health team, our obstetric team, our consultant midwife, the wider community midwifery team, so the rest of my team, and our community teams that were linked to the hospital, because she was planning for a home birth. So we had to make sure that all of our teams were aware of her individualized plan in case it wasn't one of us that went out to her home birth, but it was someone else, and her GP as well, to make sure that they were aware because of her medications that she was on, to make sure that they were aware of the full picture in case anything came up in any of their reviews. So the outcome for Lisa was a lovely one. So she continued with her enhanced midwifery care at home with me. She then gave birth at home at 41 weeks, so she thinks she was very close to 42 weeks. Her growth all throughout on our measurements was tracking appropriately for her, and she had a healthy, proportionately sized baby for her. So we had no problems with the growth of this baby. We did not have a baby that was too small or too large and caused any issues. We did have towards the end, she was getting to close to the time where we'd be thinking about induction of labour and referring to the hospital. So we started having discussions about what would we do if we got to that point. So a lot of the enhanced care for Lisa was communication and managing expectations and making sure she knew, okay, so next time I see you, if you're still pregnant, then this is going to be the discussions we're going to have. Here's some information so you can read about it before we have that discussion, so I'm not overloading you with information all in one go. She did have her baby, I think, the day before I was about to see her for that last appointment where we were going to have to start making more individualized care planning, talking about that induction. So she got that baby just before. Again, no issues during birth. So we had a lovely home birth in the pool. So all went really, really lovely. And postnatally, baby grew really well, feeding went really well, and for her mental health, all of that was all lovely, and we didn't have any relapses or any further referrals that we needed to make throughout that postnatal period. And to top it all off, she went on to have her third baby under my care again. Again as a home birth, and again we followed the same individualized care planning for her, with the old school growth protocol, and again we had no issues with her third baby either. So if we hadn't had that individualized care and she had just gone with the routine, the outcomes potentially could have been different for her specifically. And so this is one of those cases that points out how important it is to look at every person, and holistically, and look at all of their background, all of their wants and needs, and making that plan with them and involving them in that plan, rather than going, well, this is our protocol, this is our procedure, this is what we normally do, so you have to stick to that. Whereas midwifery is one of those careers where we are massively looking at our individualized care planning to really make the best outcomes that we can for our women, birthing people, their babies, and the family as a whole.
Thank you so much for taking the time to give us your presentation today. It's really fascinating. And that's the end of Healthcare Careers in Focus for this week. Goodbye.